Hello, my name is Michael Burlow, and I am the Administrator and Vice President of Hospice for Thema Health Services and Maggie's Hospice and Palliative Care. We are one of the larger hospices across the state of Arizona, with Thema Health Services locations in Phoenix, Tucson, and Globe, as well as Maggie's Hospice locations in Flagstaff, Cottonwood, and Prescott. This presentation will give an overview of palliative care and describe how hospice services are integrated within the palliative care realm. After viewing this presentation, I hope that you'll come away with a basic understanding of the concepts of end-of-life care, including what is palliative care and the difference in palliative care models. Additionally, we'll discuss how hospice is part of palliative care, but there are philosophical differences. I'm going to start by giving a basic definition of palliative care, which is essentially a service that's provided to treat those individuals who are experiencing an illness that results in physical issues, intellectual or emotional issues, social and even spiritual issues. The goal of palliative care is to optimize quality of life. A definition from the NHPCO is provided here, but to summarize, it's a service that's intended to restore individuals who have an illness to their highest possible functional level. My favorite definition of hospice can actually be traced back to medieval times, and it describes hospice as a place of shelter and rest for the weary or ill traveler who's been on a long journey. In our society, hospice is part of palliative care, but it's the final phase for those who have been on a long journey of dealing with an illness. This is my simple illustration to help indicate where palliative care and hospice fit within the medical landscape. My illustration shows the medical circle of life, or in this case, the semicircle of life, that begins when we're born. We start with care services that we call curative care or aggressive care. That is, if something happens to you, in most cases, we have the science and medicine to fix it. For example, you might fall and break your arm. We x-ray it, we fix it, cast it, and over time you heal. You might get a laceration, a few stitches, but soon you're better. However, as we age and our bodies change with age, you might eventually reach a point where you get some illness, and with all our modern science and medicine, we can't fix it. We don't have a cure. However, we can make it better. This is where you enter the palliative care realm. For example, you might get diagnosed with COPD, or heart disease, or Alzheimer's, or some form of cancer that does not necessarily result in dying in the near future. Palliative care services address these illnesses with the goal of bringing comfort while you're receiving treatment. It might involve addressing pain issues, or helping maximize treatments for shortness of breath, or perhaps treat the symptoms you receive during chemo or radiation. One of the main goals of palliative care is to keep you as functional as possible, keep you out of the ER, and try to make every day the best day possible. Now, if you kind of look over at the end of my circle, you'll see that as we continue to age, you'll eventually reach a point where your doctor might say, given your current illness, if you continue to decline, we don't have any further treatments available. And if things don't change, you have about 6 months or less to live. This is where you enter the hospice realm. And while nobody has a crystal ball, it could be 6 months, it could be less, it could be longer. This is what qualifies you for hospice. This illustrates that hospice is part of palliative care and is that final stage of the long, weary road traveled in the medical process. So the basics of palliative care revolve around an individual who's been given one of these diagnoses of a life-limiting illness. But that's not necessarily limited to older folks or someone who is nearing the end of life. Certainly a younger person who has been given one of these diagnoses could benefit from palliative care, as the goal is to improve the quality of life. Palliative care is usually performed by a physician or a nurse practitioner who's working in coordination with primary care. That is, it's not one or the other. Palliative care is an added layer of support to medical services that are already being received and should be facilitated as a partnership, sharing information with the common goal of improving the patient's health. Palliative care is usually conducted about once a month, sometimes more, sometimes less, depending on the patient's needs, again with the goal of improving functionality and keeping an individual out of the ER. Palliative care should not be considered in emergency situations. It's for support with the goal of avoiding emergency situations. And someone who is in an emergency situation should seek emergency services. An example might be perhaps a COPD patient who can no longer get out of his house to see a physician or has exacerbations from a cold or allergies. A visit from palliative care providers can assess the situation and provide appropriate medications and help restore functionality and may keep somebody out of the ER so emergency services are avoided. And as previously indicated, sometimes palliative care is the conduit to hospice services. So what is the model for palliative care? I once heard someone say, if you've seen one palliative care program, you've seen one palliative care program. That is, there's not a standardized model currently. Some programs utilize a physician to make visits. Some programs use a nurse practitioner. Some use both. Many programs involve chaplains. Most programs involve a social worker and sometimes other disciplines. Palliative care programs are currently being initiated across the country, utilizing a variety of different models depending upon available resources. Palliative care is generally billed through Medicare B. So who is a candidate for palliative care? Certainly those individuals who've been diagnosed with a chronic disease process like heart failure, COPD, cancer, liver or kidney disease, as well as those who have persistent symptoms related to these diseases like pain, shortness of breath, anxiety and depression, and nausea and vomiting. Ideally, people who benefit the most from palliative care are those who have one of the previously mentioned disease processes and find that their condition is getting worse. Their symptoms are increasing, or perhaps they're making frequent trips to the ER or urgent care. Their ability to function is getting worse due to pain, nausea, weight loss, anxiety, or lack of sleep. In general, their ability to enjoy daily activities has been reduced due to their disease. So now I want to focus on the palliative hospice realm. That's where the doctor might say, given your current diagnosis, if things don't change and you continue to decline, you have about 6 months or less to live. Typically what we see with folks at this point is they start to experience the stages best described by Elizabeth Kubler-Ross that include denial, anger, bargaining, depression, and acceptance. This is not a linear path. Sometimes people will jump from one stage to the other, oftentimes visiting one stage more than once. Once a person enters into the hospice realm, there's a philosophical shift from aggressive or curative care to comfort care. Both the individual and family should be comfortable with the idea of not going to the ER or urgent care anymore for aggressive treatment and should be resolved with the idea of just seeking comfort care with hospice in their environment for whatever time remains. I provided a diagram to show the process that hospice utilizes. The important thing to understand is that the doctor has estimated that the patient has 6 months or less, but the patient can remain on hospice as long as they continue to decline, even if that exceeds 6 months. Hospice works in what we call certification periods, as illustrated below. The first 2 certification periods are both 90 days. That is, in essence, the 6 months that the doctor has estimated that the patient had to live. After the first 90 days, a nurse will conduct a full assessment documenting the decline that is then provided to the physician, who will approve the patient going into a second certification period. If they continue to live after the second 90-day certification, they enter into 60-day certification intervals. Prior to each of these 60-day intervals, an NP or physician must go out to the patient and do an assessment or a face-to-face to verify that the patient continues to decline. In this fashion, the patient remains on service as long as it takes until they pass, as long as they are declining. If they improve at some point, hospice has to graduate them off of service. Once an individual starts hospice, they are part of a care team that consists of several disciplines that work to provide them palliation and comfort. The head of the team is the RN case manager, who works with the hospice physician to address symptoms that help achieve comfort. Other members of the team are whatever the patient wants to have included. A social worker may help with social issues and end-of-life planning or community access to resources. A chaplain may bring spiritual guidance and comfort to the patient and/or family. CNAs help with activities of daily living, and volunteers can help provide additional socialization. The patient's team may have a few or all members of the team depending on their need or desire. Hospice works in 4 levels, starting with routine care, which is where hospice comes to whatever environment the patient is living in, whether that's a private home, assisted living, group home, or skilled nursing facility. Weekly visits are established at whatever interval meets the need of the patient. For example, a nurse may come twice a week, a CNA may come 3 times a week, a chaplain and social worker may come once or twice a month. Respite care is designed to give the caregiver relief. This is a situation where the caregiver needs a break from providing primary care. The patient is then moved to an inpatient unit for up to 5 days so that the caregiver can have a break. General inpatient care is utilized when a patient has a symptom that's out of control. This is a scenario where a nurse who is visiting the patient in their home or environment is there for several hours and can't seem to get a symptom under control, for example, nausea or pain, in which case the patient is moved to the inpatient facility, which then acts like the ICU of hospice, and the patient remains in that facility until the symptom is under control, or in some cases, the patient ultimately passes away. Continuous care is a very similar situation where a symptom is out of control, only in this situation, the patient can no longer be moved, and continuous care is provided in the home up to 8 hours a day to address the symptoms in order to bring relief. One of the main roles of hospice is to provide teaching to help the patient and family understand and prepare for many of the end-of-life issues that may occur. Symptom management is one of the major objectives of hospice. Teaching families what to expect helps relieve fear and anxiety. The body is amazing in the way that it protects itself. As a result, some symptoms appear to be frightening when the body is just doing its job. It's the role of the RN to help the family understand. For example, modeling sometimes occurs when the body channels blood and oxygen to the heart and brain to preserve life. It does this by channeling the blood from the extremities. So sometimes you might see the fingers and the toes and the lips turn a bluish color. This is simply oxygen being channeled to the heart to protect itself. Chain stokes is where a body is trying to achieve more oxygen to the body by blowing off carbon dioxide. This results in erratic breathing at the end of life. Sometimes secretions form and a gurgling sound is heard. This is from the inability to swallow normally as you and I do throughout the day. Suctioning often makes this worse by generating more secretions. Medications may help. Sitting the patient up or turning them on their side may also bring relief to the distressing sounds. These are just some of the teaching moments that RN case managers provide to help achieve comfort for patients and families. One of the main reasons that folks have a difficult time transitioning from palliative care to end-of-life palliative care or hospice care are the myths that are associated with hospice care, such as equating hospice with death. Hospice is not about death. It's about comfort for whatever time an individual has left. The objective is to make each day the best day possible. The focus is not on death, it's on symptom management, achieving final objectives, and finding peace at the end of life, whatever time frame that is. Some folks believe that they can go live in a hospice facility. That's not true. Hospice facilities are for the respite and GIP situations that I previously described. Once a respite or GIP situation concludes, the patient must go back to their previous living arrangement. Some folks think that they cannot afford hospice. In general, hospice is paid for by Medicare and many private insurances. and there are very few situations that involve out-of-pocket expenses to a patient. Some people believe that all hospices are the same. That is only true to the extent that we all have the same Medicare rules to follow, but how those rules are interpreted may vary. For example, Medicare states that an RN must visit a patient at least once every 2 weeks. Some hospices may follow that guideline, while others may provide a nurse once or twice a week or more. Additionally, having a good hospice team will determine if good hospice care is provided. Some people believe that hospice covers everything. Hospice covers anything related to the diagnosis that the patient is brought onto service for. For example, a COPD patient might have their medications such as steroids and inhalers covered, as well as their oxygen, medical equipment, and any other medications related to comfort, such as pain meds, nausea meds, or bowel care. However, if they are also a diabetic, hospice does not cover that unrelated disease. While hospice will ensure that the refills are done for the diabetic meds, the cost for those meds would still need to be covered by the patient. Hospice is available 24 hours a day. If you call us at 2 in the morning, we are coming to your home. But there is a misconception that we are in the homes providing custodial care throughout the day. Hospice does not stay in the home, and most of our visits are an hour or so depending on the need. The main thing is that hospice is not in charge. The patient and the family are the captains of the ship. Nobody can tell you that you have to be on hospice or that you need to be on any particular hospice. You have the right to go on and off hospice as you see fit. If you don't like your hospice, you have the right to change. If you don't like your nurse or any other member of the team, you have the right to ask for a change. This is your final journey, and it needs to be right for you. So exercise your right to choosing the team and hospice that you would like. I hope I have provided some insight into palliative care and end-of-life care. I'd like to thank you for taking the time to watch this presentation.